Chelsea. નથી જરૂર.
We wait for some more time. Let others join. We'll start in a couple of minutes. Please wait.
Good morning.
Sorry, good morning, Dr. Nandini.
Keમ છો?
It's fine. We'll start in a couple of minutes now.
Yes. Sure.
Join.
Yes.
Okay, we can start now. So, good morning all. Thanks for joining. Welcome back to Saturday Club morning meeting. And today, I'm going to present something of interest to all of you. Whenever there is a paucity of speakers or there's a crisis, we usually, the founder members or the active members of Saturday Club, chip in with our own presentation. So today is that day when I have to chip in with my own presentation. And usually what we do in such case of short notice is that whatever we have prepared in last few days or presented somewhere, we try to present the same thing here. So this is one presentation I had made in Gujarat midterm conference of IAP at Vapi a few days back. So let me share my screen. Yeah, here we go. So are you all able to see my screen and hear me well?
Yes, sir.
Yes, perfectly well.
Okay, thank you, Kiran bhai. So dealing with difficult parents and patients. I mean, this is a pediatrician's perspective, but I'm sure all of you who are dealing with patients would connect with this topic, because in our day-to-day practice, we find a lot of challenges. But at the outset, I would like to clarify that this difficult, the word difficult, is a misnomer here, because we as doctors have to cater to all kinds of patients. We cannot categorize them as easy patients or difficult patients. I consider them more of challenges that we face when we deal with the parents. So let us talk about the challenges while we deal with the patients or parents. Now, here are some clinical scenarios or clinical pictures that we see in our clinics. So usually when we talk about an academic topic, we start with a case presentation. So here something same I am doing. I am presenting few scenarios that we see in our clinics in day out practice. So father walks in and says he has an appointment for that particular time. The receptionist does not find the same in her list. And then the father picks up a quarrel. And ultimately it turns out that some other person had taken appointment for some other clinic. So this kind of things go on in our OPDs. Then doctor asks, what are your concerns? The parent says the counts have increased. CRP is the main problem. There is infection. Child had typhoid fever 4 to 5 times in last few months. And a teenager walks in and he complains that he has adult ADHD, he has post-traumatic stress disorder, he has depression. So they come with all kind of diagnoses made by themselves. Then we as pediatricians face a lot of struggle on the examination table. The child cries, clings to mother, who does not put the child on table even after you patiently wait for several minutes. And father is indifferent, sitting on the sofa or chair, and he is busy with his mobile. The mother says to the child, don't cry, beta, doctor will give you chocolates, which I never give. She will say that we'll beat up the doctor, okay, but please let him examine just now, then we'll later on beat up the doctor, okay. And then the mother is reluctant to undress the child for examination. And we as good clinicians would always like to undress the child before we examine. A father wants to discuss about platelet count of 5 lakhs, which is beyond the reference range. He also wants to discuss about borderline low MCV. He is not a medical person, but he has read this reference range, and he's losing track of the main issue of that illness to be explained to the father. And he is busy with analyzing the laboratory reports he doesn't know much about. An ACP father, IPS officer, and an IAS mother, a power couple, walks in, and they have a child with some skin lesions. The father does not want to give any history. We as pediatricians take up all kind of history, like from birth onwards to family history. Especially in case of skin lesions, we need to inquire about family history of atopy. So as a good pediatrician, we would like to go into whatever the presenting complaint. But the father doesn't want to give any history, as he thinks the doctor should see the skin only and finish it. He is in a hurry. And when told about eczema, the IAS mother quickly looks into the Google and argues that this lesion doesn't look like eczema. And there are people who are in a great hurry. An admitted patient is just a little better, but you think he requires a couple of days more of indoor treatment, and father is adamant on taking a discharge. He says that I'm losing a business of few lakhs every day if I stay in the hospital. Now, suddenly he realizes that he's losing his business by being in the hospital. A patient admitted with 7 days of fever, very prolonged fever, and clinical diagnosis of enteric fever has an afebrile period of 10 hours and they want to go home again. So difficult patients or challenging patients and parents, the encounters are everywhere, anytime, at all levels of care. Name the situation and you will find the challenges waiting for you. So who am I to talk about this? I think everybody can talk on this topic. And once I finish my talk, I'll invite a lot of comments from all of you. I see my friends who are having big setups here, so they will also like to share the kind of challenges that they face. But who am I? So I'm trying to clarify why I have taken up this topic for myself. I'm in practice for last 40 years, and I have this habit of learning and sharing knowledge. I'm a perpetual student. I had a long stint with Baroda Management Association and organized a lot of national conferences on healthcare management. Dr. Jagdish Bhai also was part of 2 national conferences that we organized for hospital management. And we picked up a lot of topics like management, accreditation, insurance, etc. And I was convener for IIP Art and Science of Pediatric Practice program the way back in the year 2005. And I organized several workshops on practice management. And I embraced technology early on in 1998, and I held the position of chairperson of our computer group of IAP. So with this background, let me elaborate more on the challenges that we face. The appointment headaches. What happens is that the parents who phone up, they are not able to talk properly on phone, taking wrong notes and messing up with appointments like time, token number, days, etc. They have taken appointment for, say, today, and they don't turn up today. They'll turn up tomorrow that we have taken an appointment, but then they have messed up with the date and day. Taking multiple appointments for same patient by different person. Kaka lidhi hoy, masi lidhi hoy, mama lidhi, people, I think visiting a hospital becomes a family issue. So a lot of people get involved in taking appointment, and you end up with multiple appointments for the same patient. Then there are latecomers. Somebody who runs a clinic with a discipline kind of thing where they want the patients to come only by appointment. And when the latecomers come, they also mess up the schedule. And then there are dropouts for multiple reasons. They just don't call up that, okay, we are not coming. But when asked, because they have an appointment, they don't turn up, our staff will ask them, why do you not come? Then they will say, in the morning, child had fever. Now there is no fever, so we have not decided not to come. Then there are umpteen number of punctures which happen to the vehicles for the latecomers. They always have this excuse that there was a traffic jam or there was a puncture in our car. And there are walk-in patients despite knowing the system. For years, I've been running the OPD with a system of appointment. Most of the people know about it. There are old patients who have visited our clinic, but still they will walk in and they don't take appointment. So these are challenges of appointment. And then there is wrong or exaggerated history given at reception to get an unscheduled consult. They walk in and they say that, okay, my child has fever, high-grade fever, this is happening, what is happening? And then what happens that the child may have acute symptoms which are of little importance, but they actually bring up with some very chronic condition. They have sort of resorted to a shortcut where they would say that my child is currently sick, very sick. You take him in, and then we find that they have actually come for a very chronic complaint. So of course, all of you know that when there is a child who has come with a lot of chronic complaints, long duration complaints, you have to spend a lot of time, and that again messes up your schedule. And then there are online blues, like a patient may walk in with appointment given by some portal like Just Dial. I mean, these days they come with appointment that we have taken an appointment on this portal. Now, we don't have anything to do with that portal, but still they will insist that we have taken an appointment. It's very frustrating to explain that we do not have anything to do with Just Dial. At reception counters, a lot of encounters can happen, like some people are in a mighty hurry. They do not want to spend time on some essential steps like registration, making a file. I mean, this is the kind of flow that any pediatrician's clinic you will find. That first there is a registration, then we make file, we do anthropometry, enter all the measurements, then we plot the charts. So somebody else does it, doctor doesn't do it, but this is happening in most of the pediatric clinic, that they have to go through a schedule of things that happen. So plotting of charts, immunization records, we update all the old records. If suppose a new patient has come and brought some immunization record, we update in our file so that we can counsel them better. Then all the patients are subjected to blood pressure measurement, SpO2 measurement. Now, primary history is taken by the assistant pediatrician. There are many colleagues of mine who do have assistants who would take the primary history. Now, all this they have to go through and they are not ready. They are in a hurry. Then there are patients, in spite of having a display on the board, they pick up sort of arguments with the receptionist about various kind of charges that they have to pay. Waiting time is an eternal dissatisfaction. All of you will agree that you can never satisfy all patients about how much waiting they have to do in your OPD. And we in our clinic, what we do, we have written up some 3-4 very relevant reasons why we cannot keep all the appointments in time. So despite written and verbal communication for more common causes of delay in pediatric practice, there is always something happening at the reception counter where they are grumbling about a lot of time they have to wait. Then what kind of parents or clients we get in our clinic? So they are sort of personality disorders in a lighter manner. There are people who are self-styled boss. They want to order around all the places. Then there are people who come with hyperinflated egos, with a lot of hangover of their position, like those who are filthy rich, with a lot of arrogance. Then there are people who come with power in their hands, like politicians, IT department people, IPS, as I said, an example. Then they want to throw their weight around and they are quite hyperactive in getting the things done fast with a shortcut. Then there are parents who are introvert. They do not speak much. We want to take a detailed history, but they just won't speak up much. And then there are parents who are very aggressive. Then there are parents like those who are those, I call them as chaddidari technocrats, techies, like they come and they have a lot of suspicion about how we handle the things, because they have some false pre-visit knowledge derived from Google, and they are a lot of skepticism you can see on their faces when we interview them. Then there are NRIs who consult you as a compulsion. They have to come. That is why they come. And they are also skeptic about medical care in India in general. Then there are patients who would show that they are very affectionate to you and they say that they want to project themselves as a very close to you. They will talk about lot of non-important things about their relationship with tamara agamna che, tamara bhaina mein aar che, tamara they spend a lot of time. They try to be very close to us so that they think that they will get more attention. Then there are true psychiatric disorders. Some of the mothers, at least in our practice, we find who have postpartum psychosis and they behave very weirdly. And then we have to actually make a diagnosis, help them to get over that disorder by a proper referral. And there are parents who come with a lot of stress which they are carrying from home or from office. They boil up in our OPD. They vent out their anger on our staff. And then once they realize that everything has settled down, then they will say, "We are extremely sorry. We did not mean to hurt you or insult you." Having seen the encounters at this reception, etc., now let us look at what is happening when we actually start taking history. So there are silent parents, so who do not speak much. Yesterday only I had parents as well as child speaking. When we start talking to them, they just don't speak anything. We have to sort of force them to speak and tell us something why they are there. Then opposite to that, there are storytellers. They want to overwhelm you with a lot of information, which is actually not necessary. And we have to often cut them short very politely that we let us come to the main point. Then, sorry. Then there are medics, paramedics, and Google doctors. They have a lot of things to know. Yesterday only I had one patient. The child had little allergic rash. Second episode, it was very mild. So I explained them various avoidance measures for these kind of rashes. And the father came up with the question, sir, this is internal or external? Whether this is a metabolic disorder or not. So I was totally flummoxed that what is he talking about? But then it appears that he had gone through some Google article on, he must have Googled allergy, crash or urticaria. I have a habit of putting diagnosis on our case paper. So he must have typed urticaria in the Google, and then he must have plenty of information on that. And then they want to clear their doubts. So in such cases, we have to really tell them that, okay, I cannot answer all your Google questions. What comes to your heart, ask me. Then there are inquisitive parents who want to know about justification for treatment prescribed by another doctor. It's okay if they ask us about our precision, but then they have a thick file with a lot of precisions, and they ask us, sir, આ બરાબર કરેલું કે આ કેવું હતું, તમને શું લાગે છે? Then there are pseudo leaders, like they who want to lead the discussion. Usually with a child, the grandfather comes, grandmother, parents, sometimes some second degree relative would also come. And there is one personality who thinks that he can control the thing. So when the history is asked, he will start answering it. But in a minute or so, when we ask details, he is totally lost. Then he will start calling someone to get the right history. Or then he will say, okay, હવે તમે mother ne પૂછો. So these are the kind of patients who waste a lot of our time by just jumping into the bandwagon because they are there to impress others. Then there is a lot of discrepancy in the history. Primary history, in my setup, when a doctor takes a primary history, the mother may be there. When they walk in my room, the mother and father both are there. And then we find that there's a lot of discrepancy in the history. And fathers, I have seen, most of the time they are very busy with their phone, and they often appear very indifferent to what is happening there. Now on clinical examination, they are not ready to go through thorough examination, not ready to undress the child, asking to recheck. Like say, we have finished everything, and they will say, sir, હું કહેવાનું ભૂલી ગઈ. તમે એનું ગળું જોઈ લો ને બરાબર. Now we have already seen the throat and tonsil. As a part of our physical examination, we never lose to see that. We always see. But then they want કે ના એને મોઢામાં ચાંદી છે, જરા જોઈ લો ને. So again, we have to get up, re-examine the child. Then they often forget to mention some concerns during history taking, and then they mention it at the end of the consultation. So we have to re-deliberate on that. So when we examine the patient, then we try to explain the diagnosis and the treatment part. Sometimes we find that they are not paying attention. They are lost in their own world. They have their own thought processes going on. And when we are explaining in detail, they just don't pay attention. Then they pop up a question. After full explanation, asking ridiculous looking questions like, for example, if we have made a diagnosis of asthma in child, so you'll ask, so doctor, my child doesn't have asthma, right? So I've been telling them everything about asthma for 15 minutes, and then they come up with this kind of, often we understand that they are under stress and they are in a denial phase. So sometimes they express their emotions in this kind of question, but often I find that they have not been attending. After explaining a serious disease, so doctor, there is nothing to worry much, right? Then the question, disputing the diagnosis, at that lady IAS, question my diagnosis with eczema. Then they express unjustified fears about side effects. The moment you prescribe anything, like recently, we had a case of Kawasaki disease, and we in detail explained about IVIG, steroids, etc., including their side effect. They will still be very apprehensive and keep on questioning about. Even with simple drug like paracetamol, they will try to relate to some symptoms which appear after paracetamol. They will always suspect that this is because of the drug. And of course, Google questions are a big headache. Now, investigations, insisting for investigation. Some of them have made up their mind that they want the investigations for their child. So in spite of telling that, no, this is fine, this child doesn't require any investigation, like say recurrent abdominal pain, which is more often psychogenic in nature. So we analyze, we explain them, we counsel about what is happening on psychosomatic front. But then they will insist that, okay, sir, khali USG karai do, phalanu karai do. Then presenting with investigation. This is where this has become very common. They come with a lot of reports, and before we ask what is happening, what are their main concerns as far as symptoms are concerned, they just present with the Sahib, file joilon, badda andar report ને બધું છે જ, and then they ask us to interpret the reports without actually going into details of what the patient has. They try to study and interpret each parameter mentioned based on the reference range. Then regarding follow-up and compliance, there are habitual defaulters. No, they come for 1 or 2 visits, even in a chronic condition. As per our instruction, they don't come for follow-up. They come for follow-up after several months or years for chronic conditions like asthma, enuresis, and constipation. And then meanwhile, they have messed up with the regime. They make their own changes in the regime. Like, so these are conditions where you actually schedule, and depending on the follow-up, we change the doses, etc. Like say in constipation, laxative, we start with disimpaction, then maintenance, then tapering. But they mess up with the whole schedule, and they come after few months or even years later. And they make their own changes in the regime. And when we ask them, they said, "Sir, tamej kidelu hai." No, they attribute a lot of their action falsely to our advisor. You told us, so we did it. Now, what can we do? I mean, I spent some time on actually, narrating as to what are the challenges that we face. And I am sure most of you would even add to these challenges. This is something which I have encountered. They are not very often, but they do happen, and they do sort of require you to take some action. So we need to do something on these challenges. So in short, the message is that we need to understand the dynamics, the parent's perspective, your own perspective, how you want to run your practice. And in doing so, we must avoid our personal biases. Over a period of years, we have certain things which are set up in our mind. So they determine our beliefs and emotions, and then our reactions. So we need to have a multi-pronged approach where, like in any disease, when we approach, we talk about promotive, preventive, and curative. So this is also a clinical challenge for us to manage the patient. So we should look at from this perspective, that how to promote less hassles for the patient, how do we prevent certain conflicts, and how do we act when there is actual conflict happening. So the answer is that we need to have systems in place, SOPs and systems in place, because once your system is running like a machinery where certain set protocols are made, these systems will take care of most of the diversions which happen. And of course, self-growth. When I say self-growth, it means growth from within. We need to work on our own mind, and we can bring changes in the way we practice by changing our attitude to the patient, attitude to the practice as a whole. But remember that growth is never a linear acceleration. It's never a linear acceleration. It's always up and down. So over a period of time, we all mature, we mellow down, then we metamorphose to manage the patients better. Of course, at 64 or 65, how do I manage my patients? It's definitely very different from what I did at 25 or 30 years of age. So we do, over a period of time, we metamorphose, we grow from within, but then it takes many years, it takes many mistakes before we mature. So it's good to think now as to what I can do now, rather than waiting for experiences to teach us. So that's the kind of thing that I look at. Systems in place. I always say that we need to keep on working on our systems. We need them to change according to the time and circumstances. So we need to improve upon our systems time and again. But the first thing is to set the systems. So prepare and implement standard procedures, so that everybody who is involved in handling the patient knows about that. This is our protocol. We need to follow that, so that everybody should be on the same page. So prepare and implement SOPs, and a lot of at all levels which I described that we face the challenges. You can implement, you can prepare SOPs, and you can implement that. For example, appointment. So for appointment, you need to have a patient-friendly system. Depending on the kind of demographic data that you have about the patients who come to you. Like in your practice, if you have a lot of outside patients, those who travel to see you long distances, we need to make special provision for them, because they travel a lot. I get patients from MP, like say Ujjain, Ratlam, etc. Sometimes they get up early in the morning, 4 o'clock, 5 o'clock, they catch a train, they come here. And then I said, okay, our staff will say, no, morning appointment is full. You need to take a afternoon appointment. So when do they get back home if we see them in the afternoon? So we need to make a special provision for these outside patients whom you have to give a priority. So this is just an example. The consultation cycle ensure a smooth flow. The patient need to be escorted and informed in advance. So when you give an appointment in your busy clinic, you need to tell them that when you come here, that's your reporting time. After this, you will go through these steps. So be prepared to spend an hour or 1.5 hours in clinic actually when everything is over. So they should be prepared. Otherwise, what happens that these days people are very busy and they have also very tight schedules. So if they think that the 9:30 is appointment, I should be free by 9:45 or 10, and that doesn't happen. When that doesn't happen, there is a quarrel that why are you taking so much time? They are reluctant to go through the protocol. So if they have been informed in advance. What I do is whenever a new patient takes appointment, we send a PDF prepared about how they will have to go through various steps in our OPD. So inform in advance, and when they are here, in our setup, somebody has to take them along to all these things. That somebody will escort them to say immunization counter. There somebody will take to, and the same person may take them to BP, SpO2, then primary history taken, and finally the final consultation. And after that also, they need to be informed about how to understand the medications, which staff will explain them the medication, who will see the medicines again. So if you are practicing well with a lot of systems in place, that should be informed to the patient, and somebody has to guide the patient so that they are not lost in our OPD. Then billing should be transparent. We must display all the charges, and not only MCI requires, but ethically also I believe that whenever we visit a cafeteria, we know that we are spending so much for the popcorn, like say in a multiplex, when we go for a movie, we know that it is 720 costing for large tub of popcorn and a drink. So we are not flummoxed by the kind of prices they have. So in our setup also, we need to display our charges, the common charges. You may not be able to display everything, but in pediatrics, very easy. We display our consultation charges, new case, follow-up, renewal, etc. And we display all the vaccination charges. And we need to give receipts. So there is nothing like they don't suspect us of having something under the table. Use technology to the best, the electronic health records. And I'm sure in Baroda, the pediatricians are very active, and most of them are using these EHR systems. So they help a lot. Not only in managing the patient, giving them a legible, good precision, but it helps you in managing the clinic also. So we must embrace the technology. And I did that way back in 1998. So I have more than 60,000 patients data with me, and it makes the things very easy. Some other day, we'll talk about how digitalization helps in running a clinic and lessening these challenges. And you can also give some instruction to the patients beforehand that when you come to visit, please prepare a note where you want to express all your concerns. So what happens? They forget many things. They have decided around they will ask these things to the doctor, but when they are with us, they are excited, they are apprehensive, so they forget certain things, and then again the whole thing starts again. So it's good to ask them to keep a list. And many patients these days, they come with a list in their mobile, so they one by one go all through the queries, and then at the end, I also ask them that have you finished your list or not. So that helps a lot. And always ask for feedback before they leave your clinic. Ask for a feedback in terms of in a format of a paper that you prepared, or nowadays we all have Google pages. They are self-created. If you all know about it or you do not know about it, be aware that whether you have put yourself on the web or not, but patients who visit you, they put you on the web, they give their own opinions because the Google page is made automatically. Then you can actually own that, you can claim to be the owner of that place, and then you can modify the way they read about our practice. So that's a small piece of information. Sometime later we can talk about how doctors benefit by their presence on the web. Staff is the main interface. I think they spend more time with them than with us. They may be with us for consultation for 5 minutes, 10 minutes, 15 minutes, but rest of the time, that 1 hour or so they spend in our clinic, they spend mainly with the staff, and they are our face, I would say. And we need to train them beyond clinical care. So decide and share our own vision and mission. Why am I running the clinic? So whenever I employ any new staff, I always sit down with them and tell them that what is my philosophy of running this pediatric OPD, and what do we look forward to when we deal with the patient. So they must know the owner's philosophy of running the clinic, the mission and the vision. To look at parents and patients as our center of focus. So they need to develop that skill or a sense of empathy towards whoever visits. I always tell them that no patient walks into our reception for picking up a fight with us. They are there because their child is sick. So we need to understand that why they are visiting us rather than looking at them very in a skeptic way. Impart soft skills, verbal and non-verbal communication skills. Again, a big topic for discussion. But we need to be aware about how our staff is interacting with them, the kind of language they use, the kind of body language they are using. We must teach them those soft skills also. Of course, their presentation, attire, and all that is very important. You'll all walk up in a lot of clinics where the staff is not in uniform. So you do not know whether this is a patient or this is staff. So you need to have a good attire for your staff. And they all should have a "may I help you" approach. Often we see the counters at many places, "may I help you," but are they really there, sitting there, attending to the patient's needs or not? These days, what I see, I walk into a hospital and most of the staff is with the mobile. They don't look above the table. They do not know who is standing there. I'm standing on the reception counter for 5 minutes and the lady is busy with her mobile. So all that has to be changed. Of course, quality medical care cannot be over. So that's our main thing. Quality care, medical care has to be there. What we are discussing is beyond clinical care. Then clinical ambience, yes, it should be child-friendly. There should be space. I mean, talking about pediatric OPD for adults, you may be having other ideas, but we in pediatric ensure that there is a good space for play. We need to put some play equipment, small gifts. You can all innovate actually. I, in my practice, usually give an inflated balloon to each and every child as a sort of a return gift. They look forward to it. Dr. Fuggo aapse. They may be having plenty of balloons at their home, but when they get it from the clinic, it's a prized possession for them. I've seen a child who is admitted after seeing me in the OPD. When I visit that patient in the indoor, for 7 days, he has kept the same balloon with him. So much importance they give to the small gestures that we offer to little kids. And adult friendly also, because pediatric patients come with adults. So we also need to have good space for them. And we need to engage them with some health education. These days, what happens that most of the parents are busy with their mobile while they are waiting for their turn. But you can utilize this opportunity when they are waiting in your clinic by putting a lot of health education displays. So again, this adds value to your practice. And of course, our staff is our internal customer. We talk about patients as our external customers in terms of management jargon. So our staff are internal customers. So they should also have a good ambience, good place to have their lunch or break, good space for them to keep their things, and of course their sitting, etc., should be paid due attention. If they are not happy with our setup, how can they satisfy our patients? So these are the kind of displays that you can have. Like say, in my desk, I have a big LED screen at the back of my head. So whatever I explain them on the, I have a desktop on my table. So when I want to explain something like asthma, then I show them various figures. What I'm seeing on my desktop, they can see at the back of my head with a large screen. Precision also can be explained. When they are waiting, when I'm in the other room, they can see certain health education matters going in circulation. So these are the kind of displays that you can have. You can prepare your own videos and put them on the display screen so that they keep busy and they keep learning. Sometimes what happens that I'm explaining something to the patient and then the father will say, "Sir, yes, I know that these are the things to be done because I have seen your video either on YouTube or in your clinic." So that helps a lot. That adds a lot of value to the way patients get services from our place. Communication and relationship skills, I think most important aspect of our practice is clinical, in clinical practice, to ensure that we have good communication and relation skills. So pay attention, learn and train others regarding verbal, non-verbal, and written communication. A lot of written signages you can put, or they can you can put on the this LED displays where things are made easier for patients to understand as to how the things are going to be there. Then Regarding language, when you are talking to the patient, avoid medical jargons. Art of listening, again, a big topic for a day. We need to learn that art of listening. It's not about mechanically hearing what their parents are telling, but trying to understand the feelings hidden behind the way they speak to us. When they pick up a quarrel, we need to try to analyze as to why he is upset, why he is angry. Something very hidden may come up if you little go into depth. If you listen to him carefully, if you give them a sense that no, you are there to listen to them, the real things will come up. So that's the art of listening. Giving optimum time. We often, doctors are blamed for not giving enough time to the patients. We have a lot of patients waiting outside. So when I am examining a patient, no, I am worried about how will I deal with 10 other patients who are waiting. No, that should not happen. We need to manage our practice in such a way that every patient who comes to our OPD should feel that doctor has given enough time. Avoid being judgmental and avoid personal biases against, like I talked about those techies who come with chaddi. I need to remove that bias from my mind that they will throw up some questions which are not actually relevant, or they will doubt my, that kind of biases we should remove from our mind. And use humor. If you can crack a joke, it can diffuse the situation. But we have to be very careful. That sense of humor is a double-edged sword, because sometimes I've seen a parent who came back from other pediatrician, who is a very good pediatrician, but the parent said, "Ke સાહેબ એ તો મસ્તી જ કર્યા કરે, જોક માર્યા કરે, અમારું જે પેશન્ટનું જે છે મૂળ વસ્તુ એમણે સાંભળી નહીં અને એમને હસી મજાકમાં વધારે ઇન્ટરેસ્ટ હતો." So it's a double-edged sword. Sometimes I have seen a relative of mine giving me a feedback about a very prominent physician in Baroda who was very intelligent and who used to give a very witty comments on certain situations. The relatives did not understand what that witty comment was. They misinterpreted it and they blame the doctor for not paying attention to their concern. So humor, yes, use it, but be careful. It's a double-edged thing. Now, with all these precautions, still the situations are there where you need to diffuse an acute situation. Things will come up unexpected. In spite of all your efforts, these promotive and preventive measures that I enumerated, still there will be some situation where you need to deal with it. So first thing is to keep cool and acknowledge the situation. Do not deny it. Like parents deny an acute illness, mara child na na thai shake. So accept it that there is a problem there. So once you accept it, you will be able to deal it. Keep a cool, introspect. Is it them or you? Sometimes it does happen. I mean, often it can be true that the parents are right, the patient is right. They have encountered some very negligent behavior on our staff. So we must accept that, analyze that. Is it the parents who are a problem, or is it your own system or your staff which is a problem? And give time to settle down. When there is an acute situation, just keep cool and give them time to cool down. Bring back focus on child's illness. Sometimes parents are very agitated. So, but their main focus, their main concern to coming to our clinic was because the child was not well. So if we somehow track back the whole thing back to the child's illness, they will understand, okay, this doctor is interested in what is the problem with my child, and he's trying to address that rather than going into these peripherals. Protect staff from being the whipping boy. This is happening in many clinics. It happens in every clinic, whereby the parents are very rowdy with the staff, but when they walk into our consulting room, they know that if we upset the doctor, probably our treatment will not be very good. So they are very gentle with us. Their whole behavior changes once they walk into our consulting room. That should not be allowed to happen, because staff is our interface. They are representing us. That does not mean that they become our, the staff parents whipping boy. So there are situations where I have to tell the parents or the patient that, see, you have to respect the staff. You cannot talk in such a disgusting manner to our staff. So the staff's morale will go up. Otherwise, they are demoralized. When time and again the parents pick up quarrels and they abuse them, and then we don't take the side of the staff. No, that should not happen. We should be neutral. We should take the right stand, and the staff should feel that they are under a safe environment. Then there are situations where you have to do a tactful withdrawal, but you need not surrender. There are times when you withdraw a little bit, but you need not surrender. There are situations where you think that things are going beyond certain limits at that particular time, you withdraw a little bit. Don't surrender, but withdraw. Don't be very meek and surrender. And set boundaries for all. Everybody has to be set boundaries. The parents who come there, the patients who come to your clinic, they need to follow certain rules. They need to follow certain regulations that we have made for them. Try to minimize the exceptions for the powerful people or any known people who come to you. Set boundaries for all. That will help to set a good example for everybody. Lastly, I would like to talk about self-growth. As I showed in earlier slide, that self-growth is a natural phenomenon, but it takes time. So we need to accelerate that metamorphosis. And difficult, the word difficult is a perception. We need to look at the whole practice on a larger canvas. Consider practice as your ikigai. Most of you must be knowing about this concept of ikigai, where the theory says that there are things that you love, there are things that you are good at, there are things that you are paid for, and there are things which the world requires. So I think doctor our medical as a profession, I think it fits into this theory of ikigai, because we have become doctors. We love this profession. That is why we are here. We love to help the people. Then we are good at. We have developed that expertise by our training and our updating our knowledge. The Saturday Club is a big example of how we keep updating irrespective of our age. And then we are, of course, being paid for it. We charge fees for it. And then the world needs it. Yes, world needs good healthcare system. So all in all, we are fitting into ikigai, so that there is always a purpose of life seen in the morning when I get up. I have a purpose to do something good, which I love to do. I am good at. I am being paid for it, and the people need it. So I think we do need to look at our practice in such a manner, and we need to keep sharpening our axe. That is, we need to keep updating our knowledge so that we are not making mistakes in dealing with the patients. We need to monetize our time and expertise. I have seen many colleagues, junior and even those who are in their middle of their career, they are afraid of taking consultation fees that they deserve. I always tell my juniors that as you grow, you are becoming expert. You have that, you spend time with the patients. So monetize that. There is nothing wrong in that. You may give charity, you may do charity, you may charge some people less, that's fine. But then you need to realize your worth in terms of money also. That is why, if you earn from your practice, you will be able to reinvest and improve your practice. So I always say reinvest. Learn to mind your mind, work on anger. Your anger may be overt, or you may be having a silent aggression. So we need to work on that again. That's a topic in itself. But the message is that you can work on your emotions. You can manage your emotions. You can convert your irrational beliefs to rational beliefs. You can convert your unhealthy negative emotions to healthy negative emotions, which will ultimately reflect into your more constructive and not self-defeating behaviors that we often end up if we are in anger. May not be able to meet the expectations, but can manage them. So always keep this in mind that parents are very demanding. You may not be able to meet all their expectations, but you can, of course, manage them. And it's okay to say goodbye when a time comes when a patient is too fostering, is too much reluctant or adamant not to accept your viewpoint. Then you can say goodbye to that. It's okay to not be able to satisfy everybody. To summarize, difficult parents and patients are part of our life. So they are part of practice. We cannot wish them away. So we stop labeling them as difficult parents. They are more of challenging situations or challenging people. They are few, but expect the number to increase in coming years with this advent of technology, with the advent of information being available at the click of your at the tip of your finger. They are going to ask you a lot of questions which are actually not necessary, but you will need to spend more time answering them. We need to learn parenting of parents. We need, you can inculcate your practice. You can mold your practice in such a way that you get clientele which actually they deserve you or you deserve them. So it has to be a mutual reciprocal thing where you mold your practice in such a way that you start getting patients who align with your philosophy of looking at healthcare. We need to spend more time, monetize your expertise and reinvest and add value. Keep on adding value. However well established you may be. Now, I've seen clinics where the board is there for 15 years. Nothing has chain, the board is rusting and the letters are not visible. Some of them have fallen off. And because the doctor is visiting that clinic again and again every day, he doesn't see the changes that are happening over a period of time. So we need, as we upgrade our medical knowledge, we need to have a good look at your clinic time and again about not only the functionality, but about the structural part also. And most important is that we need to relax. Whether you are in a beautiful place where you can lie down in the nature, or you are on the right side, I have shown a big horse crushing me under its hoof. No, even in that situation, we need to keep our calm and deal with the patients in a very cool manner. So thank you all for patient hearing, and I'm expecting a lot of comments from all the people who are attending, because these are very common day-to-day issues that we face. So I'm open for any comments or interactions. So over to you all.
Congratulations, Satish bhai. Very excellent talk. Lot many things to learn even at this time.
Oh, thank you, sir.
Excellent talk. Appreciate it very much. I thought we face more problems with indoor patients rather than in outdoor setting.
I see Dr. Nitin here. Nitin, are you there? Nitin Agarwal?
Yes, sir, I'm here.
So Nitin is a pediatrician and an entrepreneur, I would say. And recently he was invited as a faculty in one of the meetings in Ahmedabad IMA. Nitin, can you tell us something more about that, and then your experiences about dealing with the challenges, especially when Dr. Jagdish bhai talks about indoor patients. I think indoor is a bigger challenge. So
yeah.
Good morning, sir. Good morning, everybody. See, indoor, actually, I was to tell this point only, that sir has given good perspective about OPD. But yeah, indoor challenges are little different in the sense because monitoring becomes a big part. Many times what we have seen is when the parents are actually complaining, they have, because hospital industry is much like a hotel industry. And obviously the charges are also very high. So they try to compare our hospital services with what they would expect from a hotel. And what happens is that, the expenses become so much that sometimes it is an indirect reflection of the high fees that is being charged. So they come up with very small issues. Like very simple thing is like, in this season of monsoon, there will be mosquitoes all around. Even in our own houses and even our own bedroom, we would not be able to manage the mosquitoes as well as what we would expect. In hospital, it becomes still more difficult because the rooms are in common lobbies. And so we can take care of windows. So what would happen is they would tell you are charging so much of money, but still you're not able to manage the mosquitoes. So, it's actually an indirect way of complaining. So, this also becomes a point of dissatisfaction, which actually sometimes is not in our hands, though we have tried our best, but still, so these are few challenges. Sir told something about management. So I think that was more of an entrepreneurial workshop where we talked about, it was not about patient satisfaction, but yeah, delegation of work, which I felt was very, very important, which sir beautifully explained, that we should be able to, keep PROs. Like in our hospital, we have kept a patient relationship officer. So her job is to go and take rounds and ask only about satisfaction, patient satisfaction. And she has the liberty to ask even about doctors, whether doctors are coming, whether they're explaining, whether, they give you time. Then obviously about staff, about cleanliness, about services. So these all things matter a lot. And what I mean to, pressurize is we should be able to delegate. Not everything can be done by doctors. The hospital staff, and sometimes hospital staff is considered only as nurses, ward boys, receptionists. But I think PRO is also a very, very important part of a hospital nowadays, where they can go and as usual, sir told, a feedback at the end of the day. And the feedback should be more elaborative. It should not be just whether the hospital is good or not, and just good, bad, or average. It should be more detailed. And I think sir will be able to tell that thing better.
Thank you, Nitin, for those comments. Dr. Kiran bhai, would you like to add from physician's perspective?
Thank you, Satish bhai. You had touched almost all the aspects. Your talk was wonderful. You had touched almost right from appointment to the follow-up. We face a lot of challenges. But what I feel is that in a clinic or in a health establishment, what is more important, whether it is a nurse, receptionist, clerk, or doctor? I think all are equally empowered. So there has to be a empowerment, particularly what I feel. And in that empowerment, effective doctor-patient communication is what I say is the heart and art of medicine. That is, doctors' communication and interpersonal skills is important to establish caring relationship with patients and to achieve the best outcomes. That is what we face. Lot of challenges, no doubt. Say whatever you have told, everything about that thing. Delivering, right? Let's say in adult, what we face is the delivering the bad news, then taking the informed, sharing, consent. These are all particularly very important challenges we face right from appointment to the follow-up. But what I feel that our relationship with the patient is fiduciary, what I will say. It is based on Vishwas. So we have to be a empathetic approach rather than sympathetic approach. That is what my feeling.
Right. Thank you, Kiran Bhai, for those comments. Anybody else who would like to?
Satish Bhai, one thing I have found is that sometimes once you explain about the illness, patient don't understand it at first explanation.
Right.
So we have an assistant who again explains what you have explained,
Yes.
because it won't sink in with the first explanation, especially when it is a matter of serious illness.
Very true, sir. Especially in children, if I don't talk about serious illness, but even chronic illnesses, like say asthma, we have spent a lot of time with the patient explaining them. Then the second round will happen with the staff where they would explain all the inhalers,
That's right.
video presentation and all that. So that will reaffirm. So very true that sometimes the acceptance on the part of parents is difficult to know.
Yeah. So having a good assistant who can do that, that is very helpful in OPD.
Very true. Yes, Sant, you want to say something?
Satish Bhai, you have been inspiration since our residency days. And the most important thing we have learned from you is you keep on improving by introspection. Now, as a surgeon, permit me, but we have different set of problems. But what I have learned after running a hospital is SBAR. If you know the situation, tell the situation to the patient, tell the background, give your assessment and give your recommendation, and then take the feedback. Then this is a good way of communicating not only between doctor and the patient, but in between the two doctors also. But you have inspired us that we can succeed by our sincerity. But one great thing about being a doctor is, personal my feeling is that society is mostly very large-hearted and pardons many of the minor personal errors or faults of a doctor. So we should also be very large-hearted, and as you have very said, have continuous empathy. And if you are honest, sincere, then you will always come up winner. Thank you for the talk.
Thank you. Thank you, Hemant. So I think there are no comments anymore. So, and it's already about 9 o'clock. So we end the meeting here. We meet again next Saturday morning. Thank you all for joining. Thanks.
Thank you, sir. Thank you, sir.
Thank you.